Yes, the impact of PAXG on event-free survival was clinically and significant and statistically meaningful. In fact, the odds ratio for event-free survival was 0.64, and the p-value was 0.003, so there is a clear, crystal clear advantage in using this regimen. Actually, this regimen can be used everywhere because it is used in Italy, for example, since 5 years in the locally advanced and the metastatic disease. There is no level 1 evidence behind, but nevertheless there is a phase 2 randomized trial that was sufficient because the Italian agency for regulatory issues approved the use of this regimen. So there is no barrier to adopt this everywhere in Europe or in the US. The regimen is easy to administer, and then the toxicity profile was comparable to mFOLFIRINOX, maybe a little bit better, except for the neutropenia, grade 3-4 neutropenia, but this was related to the larger use of GCSF factors in the modified FOLFIRINOX regimen. So I guess there is no reason not to adopt the regimen in the immediate future. So this is a very intriguing question. Actually, there is no evidence that this measure is validated and is related to survival. There is a lot of retrospective data, both in the adjuvant setting, let's say in the follow-up after surgery, and in the metastatic disease. And all this data goes in the same direction, that is the use of CA19-9 has a tumor marker of progression or of recurrence is useful to anticipate subsequent treatment, and then this may have some relationship with improving survival. For example, if we wait for the radiological evidence of progression, then the risk is that our patient will not be able to receive further treatment because of clinical progression. And we know that the radiological tools that we have available nowadays are limited because they cannot see and detect a very small increase of the disease. But this is a very aggressive disease. So actually it's surprising that this kind of simple and cheap variable is not universally used in an era when we are looking for ctDNA or circulating tumor cells. So it's much more expensive, but the concept is the same. The problem is that we know that the disease is there and we just need to anticipate. Regarding the trial, this measure was used, of course, symmetrically in the two arms, so there is no logical reason to believe that this may favor one arm over the other. If any, this should be in favor of a modified FOLFIRINOX arm because 10% more patients at baseline had a normal CA19-9 value, and so were not exposed to this kind of event. My opinion on this topic is that we have to abandon the surgical classification for resectability, because this kind of classification was never proven to be of any prognostic value and is not reproducible. So I think this classification hampers the progress in the field. But if we want to stick on this for once more, then the subgroup analysis in the CASSANDRA trial showed that the 3-year event-free survival was doubled both in the resectable, so-called resectable and borderline resectable population. So at the end of the day, there is no variability. Let's say there is no evidence that the impact of the treatment is different in the two populations. There is one very relevant thing that I think is a major success of this trial is that, to my knowledge, this is the first trial, phase 3 trial worldwide that was completely supported in terms of cost by patients' associations. So the cost of the trial were covered by a couple of patient associations that are MyEverest and Codice Viola, and I guess that the trial would never have been done without them, so I thank to them.